Okay. All right. Well, welcome everybody. We'll get started right on time. I want to thank everyone for being here for our May ACFAS attendance poll. Let me answer that so I can see this here maybe. Nope, can't see. Moving it out of the way. Beautiful. Um, so answer that poll if you can for us. And welcome to the ACFAS Virtual Journal Club for May. We have Sara Kubick from the Core Institute out of Phoenix. I'm Dr. Christy King, and we also have some other visitors today, which I'd like to introduce and thank for showing up today. We have Dr. Cicchinelli, who is the Chief Medical Officer at PICA. He has over 30 years of experience both domestically and internationally as a podiatric surgeon, consultant, speaker, and educator in sports medicine, reconstructive surgery of the foot and ankle, and diabetic limb salvage, including 28 years as lead surgeon on humanitarian missions and pediatric surgery in Central and South America. He has been a senior consultant in medical education and product invention and development through North America and product invention and development through North America and EMA, Europe, Middle East, and Africa. Dr. Cicchinelli is a fellow of the American College of Foot and Ankle Surgeons and a fellow of the Australian College of Podiatric Surgery, as well as, Comunidad in Galicia and Asturias in Spain. So you really challenged my Spanish speaking and my rolling my R's there, which I'm not as good at. And then I'd also like to introduce, before we get started, Dr. Cameron Meyer. He is one of the authors of the papers that we'll go through today. And it's great having an author present as we review their articles to kind of learn more about the process and other things that they learned. So thank you, Dr. Meyer, for being here. He completed his advanced surgical fellowship at the Orthopedic Foot and Ankle Center in Columbus, Ohio, following an extensive residency at the University of Pittsburgh Medical Center. Dr. Meyer is a dedicated educator and researcher. He currently contributes to surgical residency programs through McLaren Greater Lansing and has presented and published widely on topics ranging among reconstructive ankle surgery. Currently, Dr. Meyer is residing in East Lansing, Michigan, and is in private practice. So I want to thank everyone for being here, and I will hand it over to Sara.
Awesome. Thank you so much, Dr. King, and thank you so much to PICA for generously sponsoring this journal club. So we'll go ahead and get started with our first article. This first article is a review of 399 total ankle replacements. It's an analysis of ipsilateral subtalar joint arthrodesis and associated talar component subsidus. This was done by Preisel and colleagues out of Ohio and was published in JFAS 2017. The study looked at whether patients undergoing total ankle replacement have worse outcomes with ipsilateral subtalar arthrodesis either before, during, or after the ankle replacement. So the concern is that subtalar fusion can alter the blood supply or hindfoot biomechanics, potentially therefore increasing talar component subsidence and implant failure. These authors performed a retrospective matched case control study reviewing the 399 ankle replacements. Of those total, 41 of those patients had an ipsilateral subtalar fusion. And of those 41, 33 of those were successfully matched to controls without subtalar fusion. So they matched to controls based on age, gender, as well as implant type. The primary outcomes included survivorship of the ankle implant as well as radiographic measures of the talar component subsidence. At approximately their 2-year follow-up, the study found no statistical significance in implant survivorship between the groups. Both groups had about 88 or had an 88, it was like 87.8% survivorship. There was no significant difference in radiographic talar component subsidence measurements on both the coronal and sagittal plane between the groups as well. The authors also from that data analyzed the revision cases that were done and looked at the implant type. And they found that the older generation implants, particularly in bone 1 prosthesis, there were more failures in that. Whereas there were no failures in the newer generation, the InBone 2, in their study cohort, which could contribute to better survivorships. Sweet. Beautiful. All right, so the authors had they chose a clinically important issue. So total ankle replacement patients typically have some type of subtalar joint pathology, especially these patients who have longstanding ankle arthritis due to the altered biomechanics of the subtalar joint. The concern is that a subtalar joint arthrodesis, again, may compromise some of the blood supply and therefore increase the talar component subsidence or lead to increase of failure. This rationale makes sense because we all know that the talus has a tenuous blood supply, tenuous vascularity, and any additional instrumentation, any additional screws or fixation could theoretically increase the chance of avascular necrosis or subsidence risk. The authors did a really good job on appropriately referencing the conflicting literature, concerns, again, regarding the talar vascularity and uncertainty, comparing like the stage versus simultaneous fusion. A lot of the prior studies evaluated subtalar joint arthrodesis and ankle survivorship, but they did not have any match controlled data, which is something that this study did a really good job in bringing, so they had that match control. They also have really good objective radiographic measurements as well as a survivorship comparison. So a major strength of the study is that they did attempt to control for that implant selection bias by matching the prosthesis type, which is a pretty important confounder, as kind of we learned earlier on the, like when we have in bone one versus the newer generation total ankles. Like I had mentioned previously, they had started with 399 TARs, and they specifically evaluated patients with ipsilateral subtalar joint arthrodesis, comparing to that match control. And again, they matched for age, gender, and implant type. They were not matched for the severity of the deformity, bone quality, or vascular status, which is something that could potentially be improved upon in future studies. I do acknowledge that it would be pretty difficult to match for that, especially with their smaller sample size. With 33 patients, it's going to be difficult to match all of those things. If we are able to get larger studies, that's something that we can look at in the future. They did use appropriate statistical testing, paired t-tests, Wilcoxon and McNeimer's tests, and they did set clear inclusion and exclusion criteria. As you can see kind of in this box that I outlined for you guys, the subtalar joint arthrodesis timing was not consistent. So 26 of the patients had previous subtalar joint arthrodesis. 4 of them had simultaneous arthrodesis with the total ankle replacement, and 3 of them had subsequent. There was also no CT confirmation for healing of the subtalar joint fusion. This was all evaluated through plain films. The follow-up was relatively short as far as total ankle replacements go. The median follow-up was about 24 months in the study. Most of the early total ankle failures and subsidence would likely be captured in this time, but to evaluate long-term survivorship, a longer time, 5 years or longer, would be ideal. Here is kind of an example of their methods and how they objectively measured radiographic coronal and sagittal plane subsidence. Overall, the objectives were, or the outcomes were objected, but there was lack of blindness assessment, which does increase the possibility of measurement bias. Like I had mentioned previously, there were no significant findings in the subtalar subsidence. There was a similar survivorship between the two groups, about 88%. No significant radiographic differences, which does support the conclusion that subtalar joint arthrodesis does not objectively worsen the short-term total ankle replacement outcomes. I hope that, yeah, this translated cool. So the study group did have 3 failures, did have 4 failures in each. So 4 failures in the control and 4 failures in the subtalar joint arthrodesis. 3 of those were in, 3 of the revisions were in bone 1. So I highlighted those in red. And none of those were in bone 2. The one that I highlighted in green is a saltotalaris. The tables that they had in their study were appropriate and the tables matched. They were consistent with the text that they had given. The radiographic measurements and the techniques that they used to do this were very clearly illustrated. Their figures did improve the reproducibility of the study. But again, with only having one person measure the radiographs, radiographic measurements may have limited reliability without the intra-observer variation. Overall, the study does provide useful preliminary evidence that subtalar joint arthrodesis is not clearly catastrophic to a total ankle replacement survivorship. Um, the talar subsidence might not be as common as we would have expected. This can clinically be applied to total ankle replacement candidates, especially those with subtalar joint pathology. Some caution could be taken as far as the smaller sample size of this, as well as the shorter follow group and the heterogeneous fusion times, as well as the implant era differences. That's all I have for the first one. We good if I just move on to the second one? Thank you. I think you're muted,
Dr. King, you're on mute.
There we go. Do you have the critical appraisal sheets at the end of these, at the end of the?
So I have the appraisal sheets in like my text, but I'm just kind of reading that out loud.
Gotcha. Okay. Gotcha. Yeah, because felt you hitting some of those points. So perfect. Um, yeah, maybe I know they're related to some degree, and maybe we do continue with it because I think the next study even talks about this study in their systematic review. So,
They do.
yeah, let's maybe loop them all together and go through the next study, and then we can have a longer discussion on the two of them.
Okay, perfect. Alrighty, so this next study is by Dr. Meyer and colleagues out of Ohio, published in JFAS of 2026. It is entitled Subtalar Joint Non-Unions Following Isolated Ipsilateral Ankle Arthrodesis, Systematic Review and Meta-Analysis. So this article is a systematic review and meta-analysis evaluating whether prior ipsilateral ankle arthrodesis increases the risk of subtalar joint non-union after a subtalar fusion. Ankle arthrodesis is known to increase, like kind of I mentioned in the previous article. So it's known to increase the stress and degeneration of adjacent joints, particularly the subtalar joint. It has not been previously reported on how well the subtalar joint fuses heal beneath a previously fused ankle fusion. So these authors performed a Prisma-guided systematic review using PubMed, Google Scholar, and Cochrane databases. Ultimately, of this, 6 studies met their inclusion criteria, with 3 studies eligible for formal meta-analysis. So in total, 74 cases of subtalar arthrodesis with prior ankle arthrodesis, that's a lot of arthrodesis words, were analyzed. The primary outcome was to evaluate the subtalar joint non-union rate, and the pooled non-union rate across the studies was 38%, which is higher than the reported non-union rates for isolated subtalar fusions in the general population. This is typically cited between 0 and 22%, depending on the fixation type. This meta-analysis demonstrates that patients with a prior ankle fusion were approximately 7 times more likely to develop subtalar non-union compared to patients without this previous ankle arthrodesis. Clinically, this paper is really important because it shows it suggests that subtalar fusion beneath a previously fused ankle shouldn't be considered like a routine union or a routine fusion. The findings do support more cautious patient counseling, possible biologic augmentation, stronger fixation strategies, or maybe a lower threshold for CT evaluation when non-union is uncertain. It does highlight the significant challenges of adjacent joint fusions after an ankle arthrodesis and raises, the question on whether motion preserving procedures such as a total ankle replacement, like we were just talking about, may be better and can help protect the hindfoot joints over time, which has been proven to do so. So the clinically meaningful problem that these authors selected was, again, does ankle fusion increase adjacent joint degeneration? Little data exists on the fusion, oh my goodness, fusion successes of subtalar arthrodesis beneath a prior ankle fusion. This is highly relevant clinically. The hypothesis that they came up with is biomechanically plausible because altered subtalar mechanics, increased micromotion, altered vascularity, as well as compensatory hindfoot motion can all lead to difficulties with subtalar union. This image is from Seeley and colleagues, and they described the altered biomechanics of an ankle arthrodesis on the subtalar joint. So they found that abnormal patterns of movement also leads to clinically to impingement, specifically of the posterior facet in patients with the largest increases in hypermobility. Overall, so you can see here's their PRISMA guidelines. Went from 7,800. Again, 6 studies were included in the review, and then 3 of those studies met the meta-analysis criteria. For a meta-analysis and systematic review, the sample size is a major limitation. For a meta-analysis, it is relatively small. But the statistics that they ran on this were rigorous, especially for the study and the available data that they had. So I commend you for that. There were a lot of statistical analyses that I definitely had to look up to know kind of what they meant in this. So PRISMA methodology again was used. Multiple databases were searched. Inclusion and exclusion criteria were very well defined. Appropriate analyses were used, as well as the sensitivity analysis was performed. The publication bias was also assessed. Some of the weaknesses in the article is they're kind of between the different articles. There was heterogeneity in the fixation, whether or not grafting was used. The union assessment, kind of like the previous article, the union assessment utilizing CT was not consistent throughout the articles. And the surgical technique, of course, those are things we can't control when we're doing a meta-analysis and systematic review, but just something to kind of consider. There was also some inconsistent definitions of non-unions throughout the different papers, and like I said, inconsistent imaging modalities. These results do make sense. So the pooled non-union rate, as you can see that I highlighted in red, is about 38%. This is clinically believable given the altered biomechanics and the increased subtalar demand after an ankle fusion, kind of like that Seeley and colleagues article had referenced. The statistics were appropriately used. They did a random effects and meta-analysis, odds ratio, sensitivity analysis, as well as that bias testing. They also did, as you can see here, forest plots and heterogeneity analyses, which appeared internally consistent. Their confidence interval, however, was fairly wide, which again, this reflects the smaller sample size. While there is, like I said, a little bit smaller sample size, clinically, this is an important paper. This article strongly suggests that prior ankle fusion is a major risk factor for the subtalar non-union. As you can see here, patients who previously had an ankle fusion were over 7 times more likely to experience non-unions of the subtalar joint arthrodesis compared to those without a history of a previous ankle fusion. The conclusion are reasonable and they were appropriately cautious with their conclusions. They did acknowledge the limited literature quality, again, the heterogeneity of the studies and the retrospective bias in it. Um, the results, I feel like we can trust the results. So they're biologically plausible, consistent directionality across the studies. The robust meta-analysis methods and statistical analyses were used. Um, Again, some of the things that we should be cautious with is only the three studies in the pooled analysis were included. Um, but something that this paper I think should influence and can influence is preoperative counseling for patients. Your fixation strategies, are you going to be more likely to utilize biologic augmentation for these? You're going to keep them non-weight bearing longer. So your postoperative weight bearing protocols, are those going to change? Are you going to be quicker to order a postoperative CT to confirm fusion? A major practical takeaway from this, I think, is that subtalar fusions beneath the fused ankle should not be considered a routine fusion. It's something that we need to take a little bit closer look at. And that's what sorry, I kind of ran through that.
Awesome. Yeah, no, I think both of these studies just brought up some really interesting, even just biomechanical issues with the subtalar joint, whether it's underneath a total ankle or whether it's underneath an ankle fusion. Question I have for you, Dr. Meyer. I think a lot of times our research questions start to come out of experiences and fellowship or residency. Did you run into, some non-unions with ankle arthrodesis or conversions from arthrodesis to TARS or anything that kind of stimulated your thought on this research project?
Yeah, that is a very fair question. Coming out of the University of Pittsburgh, obviously a lot of diabetic patients, a lot of neuropathic patients, a lot of hindfoot nailing. You watch enough nails kind of back out for various reasons or fail in different areas. I can honestly say that coming out of my residency training, I was under the influence that almost everybody needed a hindfoot nail or some degree of fusion. After you see a few of them fail, you kind of start changing your mindset a little bit. It kind of bears the question, do you do both at the same time? The right patient and figuring out whether or not, it's not a one size fits all situation by any means. And so every patient deserves an independent evaluation. Yeah, it started this process as it course throughout my fellowship training, really looking at periarticular arthritis. And so, where I found I used to narrow in on isolated deformities, I look at the surrounding joints a lot more closely. I try to pay closer attention to what the actual talonavicular joint looks like, what the midfoot joints look like. And whether or not down the road your periarticular arthritis is going to influence your original fixation. I do think that the current research is limited, which obviously is reflected on the presentation, and certainly it was attempted to be reflected in the article itself, and something that certainly needs more looking into down the road.
Dr. Chickenelli, having, both of these articles with either some increased risk of non-union in Dr. Meyer's article and then in Dr. Purcell's article. I thought it was interesting. I think the time to surgery was shorter in those patients that had a subtalar joint arthrodesis as compared to how long the revisions had to happen in those that did not have a subtalar joint arthrodesis. With some of this data that's out there, how does that, from a legal perspective, if you do go through with these surgeries, what should you document to protect yourself, knowing that, a subtalar joint fusion in the case of augmenting both of these is a potentially higher risk than it would be alone?
Yeah, so very interesting. I think the sort of three things come to mind as I listened to the presentation and then the conversation to this point so far with the three of you. I think the first thing, Sarah, you made a great point, and I would say optimization of the patients as far as controllable things. So, vitamin D, smoking history, albumin levels, psychosocial considerations, family support system. So optimizing everything that you possibly can in the patient selection process to try to minimize the possibility that you end up with a non-union or an issue with the subtalar joint. And then Christy, with what you're saying about this risk on the medical legal side, I'll jump into the informed consent conversation. And I want to use that word because for young professionals, we sort of, I always say there's a huge difference in any specialty around the entire world between June 30th and July 1st, right? So July 1st, it's on you. June 30th, it's not. And what you learn, sounds like you, Cameron, have learned it or are already learning it, is the conversations that you have around expectations, realistic expectations are absolutely paramount to your success. And it's not just the consent form. The best way to think of it is the informed consent document is just the memorializing that the actual conversation happened. And I think it takes us all too many years to learn that. We think, well, they signed the consent form. Well, all the consent form does in a medical legal environment is say, okay, there's a form there, but you really need to look at it. The way to look at it in private practice is that's just documenting and confirming that the informed consent conversation about all these potentialities happened. And then back to what Dr. King was saying about the medical legal risk with this is you have to broaden these informed consent conversations to at least one other family member. And I think that is a huge pearl for folks to realize. You're talking Charcot reconstructions, you're talking IM nails backing out. On the med mal side, you're talking about the risk of a below-knee amputation, and then we can extend that into wrongful death allegations against podiatrists when these things happen, unfortunately. So you've got to broaden these informed consent conversations into family members so that you have more people understanding that we're not guaranteeing things. And then I'll end, and I'm sorry I'm talking so much, but the three things are optimizing the patient, broadening the informed consent conversation to include other family members, let's call them stakeholders in the recovery of this patient. And then the final one is documentation of what their functional limitations really truly were and what their expectations are. Because when you end up with a non-union, or you end up with a TAR that's now going on to be a revisional TAR, which was in the article, right? You need to really have good documentation about where they started. What were their functional limitations? If you can't define their functional limitations on the front end, they will be piling on what they can, quote unquote, no longer do later when you have a plaintiff's attorney or a plaintiff's expert saying that they can't do certain things. So those are 3 bullet points around anticipating complications at a higher frequency, which is what these articles are talking about, than, let's say your more standard run-of-the-mill surgeries. It's awareness. It's all about awareness that these things have a higher frequency.
And I thought that was good to see that in, a lot of these research presentations. One of the things I can pull up, I might steal the screen from you for just a sec, and then I'll let you share it again. But she was hitting some points of the critical appraisal sheet. So if you guys haven't use this to look at your research studies, your journal clubs, I think it can be really helpful. In general, looking at journals is really good for your education, but I find that kind of taking it to the next level with the critical appraisal are you guys seeing the critical appraisal sheet or no?
Yeah, it's on it. I can see it.
You can see it? Okay. I just see me on one form. Okay. So just to bring up, if you guys are ever looking to evaluating any of your studies just much more critically, I think these are very good. So this is out of the University of Oxford, and it goes through all kinds of different studies. It doesn't always completely capture the podiatry studies, but you can use pieces of them. Sometimes, or many times, we're more retrospective in nature, so it's not as prospective. But I find if we look at, we can use this critical appraisal of qualitative studies for therapy studies, looking at the first study, where if we're considering the therapy, the subtalar joint fusion, and whether they did get it or didn't get it, I think that starts to help us look at if it was useful, and some of the questions that Dr. Kubick was answering for us were based on these. So was the assignment of the patients randomized? So no, it was more retrospective in nature, but they did try and do a good job of matching them through a control nature, which I thought was good, which is something that hasn't been done too much in especially that type of research. Were the groups similar as at the start of the trial? So for the most part, yes, they did match them. But I thought it was important that you brought up, not necessarily in their vascular status and other features, but as much as they could match them, they did. 2A, aside from the allocated treatments, were they treated equally? So overall, it's hard to say given the retrospective nature of that, but um, it's as close as we can get given the research and these questions. And then what 2B, were all the patients entered in the trial accounted for? Doesn't account to this since it was more retrospective, and then blinded, so it wasn't blinded. And then they didn't really go into relative risk, so we don't have to do our math today, thankfully. But I find that these can be really useful to actually look at how much of a size and effect size do you need to show a true treatment risk or benefit. So especially if you get some good randomized papers, I find with relative risks, it's good to walk yourself through this math so that you can really determine essentially the number that you would need to treat to truly see a difference, which is, I think, very important if we're really looking at ways to make a difference with the treatment that we use. So with some of your future journal club articles, it's not a bad idea to pull up the University of Oxford and kind of go through these. They do have one for systematic reviews, as you can see here, which starts to explain a little bit more of how we can use that. And I think they did a great job with the question, as well as kind of narrowing those studies down. And then inclusion criteria was very appropriate. Were the included studies sufficiently valid? I think for the most part, as much as they could be, yes. Were the results similar? They were similar, but we were able to see the 38% risk of non-union with those pooled results. And then I find forest graphs to be somewhat hard to understand and really appreciate what all of the pieces of that graph are trying to tell you. So I think this University of Oxford um, handout does a good job of trying to explain what the big square means, what the little square means, what the triangle means, and so, or what the diamond means. It's not even a triangle, it's a diamond, and how close it is to essentially one is what you're looking at in terms of what it favors. So if you get a chance with any of your future studies, I would recommend kind of pulling up this University of Oxford sheets and kind of going through it so that you can really dive deep into um, what the study is truly saying, and how uh, effective it is for your future care and treatment. But one of the questions I have that's not necessarily based on the study, we came from these studies kind of appreciating subtalar joint fusion. And you mentioned, I think, a little bit, Dr. Meyer, but what do we see that happens to the TN joint after all of these? Whether we're taking out the ankle, fusion the ankle and fusing the subtalar joint, or, if we're able to save some of the range of motion of the total ankles, but still fuse the subtalar joint, how's the TN joint doing after that? I don't know that we have any good studies for that yet.
No, we don't, and it's interesting. At least in throughout our my fellowship experience, there would be at times some partial excisions, or you're dealing with a little bit of spurs, but not really fusing, and then you're also looking into how much does a capsulotomy or a synovectomy type does that really play an important role in maintaining some degree of accessory motion, or should we look into fusing that as well? And I think that all in all, it's patient-centric. It kind of has to be, and how much arthritis is enough arthritis. It's hard to always pin down. So I think that question is justifiably still out there for sure.
Do you see much preparation with the IM nails of the joints, both subtalar and ankle?
My experience was always with an open prep. I even if it was a minimally invasive technique for joint preparation, it was still open, so at least you had the confidence that you were visualizing the joint. So everything I was doing was in an open technique. I do question some of that from a minimally invasive, probably just because of training and background and exposure. But certainly doesn't mean that it doesn't work. It's just a matter of it's hard to know for sure if you're not actually seeing the joint.
Hmm. And maybe on that, Dr. Ciccinelli, if you're not directly prepping the joint, whether it's arthroscopically or open, does that present and you experience a non-union, do you feel like that puts you at any more increased risk because it wasn't prepped, or could you use the excuse, oh, using the reamer prep the joint, or I've heard a fair amount of those along the way.
Well, so I actually think it does affect it. I really do, based on the sort of principles of arthrodesing procedures.
Mm-hmm.
However, you do need to realize that the concepts of standard of care are essentially what a reasonable person in a reasonable environment with reasonable similar training is doing. And so I think that it's really important in sort of a private practice, sort of clinical practice management sense around risk awareness and these concepts is a couple things. Know your environment and know your colleagues. In other words, build your network early on when you're out in practice if you're going to do these procedures. So you've got two entities here. You have a 7 times higher risk of a non-union of a subtalar joint fusion in the presence of an ankle fusion than you have. Let's just cut to the chase. You have the potential for revisional TARs. Okay. So you're out of your fellowship first year, you're in practice. You need to know who in town, ortho or podiatric, is doing these things and get second opinions proactively and early on, because you know that there's a higher chance of complication. And don't worry that you might lose a patient. If you're going to lose a patient because they prefer somebody else, well, that's okay. What you don't want is you don't want to end up holding the bag early on in your career, and all of a sudden you have 3 or 4 or 5 of these patients over your first couple of years in practice who are ending up in the hands of one of these other folks in town. Okay? So you gotta, I always say, begin with the end in mind, and you have to begin with the end in mind. You have to visualize what's the worst case scenario here. And you say to yourself, all right, let me begin with that and be sure I have some backup, because then when you get a non-union and they go to the ivory tower and you didn't prep the joint, and the head of ortho, I'll just make something up, the head of ortho at Northwestern University has all the credentials and the credibility and so forth, says, oh my gosh, well, you have to prep the joint. We always prep the joint. Now you're the outlier in your local area, right? So you gotta, early on in your career, you've got to know the environment. You got to build those networks. You got to ask for some second opinions before you're holding the bag, because nobody wants to accept those complicated patients later and not really knowing them. So yeah, it all matters. I mean, there's certainly great articles out there on arthroscopic subtalar joint fusions, things like that. Certainly you can preserve soft tissues, the vascular vasculature and so forth. But in general, you got to be able to justify what you did, be able to see it. And if you know there's a higher complication rate, I'm with you, Cameron. You need to see it open, maybe it's mini open, whatever. You got to be able to see it. You got to be able to confirm it and take pictures. Take pictures so you can document it. These are big procedures. And folks get in a lot of trouble in the first few years because they may have done them in fellowship, but what was the actual number? Right? What was the actual number? And later that comes up. It comes up in discovery. It comes up in depositions. It comes up a lot. It comes up a lot, and it's logical. Put all of ourselves in the same shoes. Let's say one of us needs a reverse, total shoulder, right? Or a mom does, or a dad does, or something. You go to the doc, and you're sitting there, and they're going through it, and you're like, all right, well, how many have you actually done? Well, our hospital has done X, Y, Z, and you're like, okay, but how long have you been out of your fellowship? How many have you actually done, right? They're logical questions. Patients are thinking the same thing.
That makes a lot of sense. Well, beautiful. Any other thoughts or questions on these two papers? I don't see any questions in Q&A.
I have one quick question. It's more surgical academic for you guys as the panel. So it was interesting to me, Sara, in that first article, wasn't like 27 of them already previously fused? So is there any literature or knowledge on the true issue if it's done at the same time?
So there wasn't any that I found that looked at comparing having like the subtalar fusion done previously versus at the same time. I mean, clinically, we know that, I don't know about, your guys' post-operative protocol for total ankle replacements, but we like to get them moving once staples come out at about 2 weeks and start to get them weight bearing at that time. And so given the, doing a simultaneous subtalar joint arthrodesis does complicate your post-operative protocols, your post-operative treatment for that. So while I don't have any like evidence as far as papers go clinically, it would make me nervous to do them simultaneous. If you
that makes a lot of sense to.
And they were far apart too. So in some of my training, the subtalar joint was done maybe 6 weeks before to separate them like that. But in this study, it looks like only 2 of the 26 previous subtalar joints occurred within 6 months, and the median time was 2 years. Yeah. So most of these patients had their subtalar joint 2 years or more before, and very few had it much more recently. Mm-hmm. So that would be an interesting question, just the injury to the talus that happens, and whether that would contribute more to subsidence in that situation where it's just done too close to the time of the total. That would be a good question. Might have to write that one down.
Yeah, I agree. I agree with you, Christy. I think that's a great question for someone in their fellowship as a research question to be chewing on, because what was the primary indication for the subtalar joint fusion, right? What was the primary indication? Was it DJD? Was it a previous subtalar joint dislocation or talar extrusion or something like that, right? That would obviously impact the vascularity much more than just osteoarthritis. But anyway, that would be very interesting to look at.
Yeah. And especially, if you're going from, doing the prior subtalar joint arthrodesis and then having them non-weight bearing 6 to 8 weeks, confirming usually with the CT, and then going straight to a total ankle, having the patient who has, been deconditioned, not walking on it, their bone quality not as good. I wonder if that could contribute to that as well.
Well, and I'll just tie it in real succinctly to my previous comments about knowing your sort of territory, who's around you, because there's traumatologists, and then there's sort of orthopedic surgeons. And so if in your area there's traumatologists who are seeing a lot of MVAs, motorcycle accidents, really heavy trauma to the ankle subtalar joint and are doing these procedures versus some orthopedist who's foot and ankle specialist and they're in just a big bone and joint clinic who are seeing more osteoarthritic issues, that will tilt the scales in your local environment as to what their opinions are and what their approaches are around some of these considerations, right? Be it tailor component subsidies or non-union. So you really need to be aware. I can't stress enough the importance of situational awareness of exactly who the players are and their tendencies are in your area. Doesn't have anything to do with this conversation, but the other one we see a lot is when there's a big, and you're in Phoenix, okay, Phoenix Children's. When there's a big children's hospital in an area where we have a lot of colleagues practicing, I'm telling you right now, it gets dicey. Even if you have really good training in peds, when you're doing certain procedures and there's a pediatric hospital near you, when something, is a poor outcome or something gets sideways, you have a really more difficult situation on hand because logically they're like, well, so you seem to gave great training and you're in the East Valley and, you seem to know what you're doing, but there's, Phoenix Children's Hospital right down the road. I mean, are you really doing this at the rate and volume that they are? So you can extend that to this, where you maybe have a, level 1 trauma center and they're doing all sorts of hindfoot and ankle trauma cases versus just old osteoarthritis. Lots of factors to think about.
As somebody that is going to be completing fellowship soon and is moving to another state that I'm not necessarily familiar with, the local standard of care, I'm going to be joining a private practice out there. How do you advise figuring out, what our ortho colleagues are doing? I mean, obviously it's easy to find out what the other people in my group are going to be doing, but do you have any recommendations for figuring out kind of standard of care in a new area?
Well, I got to tell you, you got to be comfortable being uncomfortable. Okay. I think one of the keys to success is just getting comfortable being uncomfortable. And you know what you ought to do is just go meet them. You just go meet them. And if they blow you off, fine. You just keep knocking on doors and you go meet them and you be outgoing, collegial, respectful, professional, and find out exactly what they're doing. Hey, offer to scrub in, refer some patients for a second opinion. That's another area we get in trouble with. People come out, they're doing big procedures. What they really ought to do is self-proctor, okay? Self-proctor yourself. There's published data now on, the risk of complications for things like calc fractures, TARs, even some of the minimal incision procedures for bunion surgeries, like what the learning curve is before your complication rate sort of flatlines or comes down. So get there and go meet them. And then, you can always hang around the operating room and look at the board like everybody does anyway, right? They're already looking at what you're doing, right? What's going on in OR5? Whoa, you guys are doing that kind of work? So don't be bashful. Seriously, do not be bashful, because the dividends will pay very, very much for you in your success. And when you have a complication, who will be willing to, be a friendly colleague and just help patients get the best care and not start throwing stones,
Thank you.
Yep. You're welcome. Good luck to you.
Thanks.
Well, on that, I'll let Sara present more about her fellowship.
Share the screen again. Blank again. Hold on one second.
Sorry, I screwed you up with
No, it just doesn't like this presentation. How's that?
Perfect. Yep, I see
Okay.
question.
Perfect. Back to that. So yeah, I'll just go briefly over this. Like Dr. King had mentioned, I'm at the Core Foot and Ankle Advanced Reconstruction Fellowship. That's in Phoenix, Arizona. Dr. Galley is our fellowship director, and our attendings are Dr. Scott, who was previously the fellowship director, as well as Dr. Udupa. Kind of just like a brief overall. One of the, I think, incredible things about the fellowship is just the vast majority or the vast different cases that we get exposure to. Being in a really big ortho group, we see pretty much everything under the sun, anything that you can do, foot and ankle. We obviously focus on reconstructive, so doing a lot of total ankles, a lot of trauma, and kind of reconstructive cases in general. My year as a fellow is a little bit different than previous years, because I am the only fellow this year. And so my schedule is just a little bit busier than kind of most years. But generally the weekly layout is clinic 1 to 2 times. Typically for me, it's about a half day, and then an OR the rest of the week. We do have research and admin time kind of as needed. And I am also on call every other week, but it's not like residency call, which is fantastic. When I first found out that I would be taking call every other week, I was a little bit nervous, but it's clinic call that I take every other week. So I hesitate to even call it call, especially after what residency was. Our responsibilities as a fellow, and I'm sure this is pretty much the exact same kind of around, the different fellowships, but we're very active in the surgical cases, looking at obviously pre and post-op. We do some dictation. Clinic is kind of on the back burner. I think one of the other really nice things about the program is, like most things, you get out of it what you put into it. And talking with my attendings and saying, hey, these are the things that I feel like I really need. These are the things that I want to work on, I want to improve on. And they are like, yeah, they don't function. Their clinic doesn't function based off of a fellow. Their OR doesn't function based off of a fellow. So I am primarily there to learn and to do, which is really nice that I can kind of pick where I think my learning is best or what I would like to do. We do have weekly radiology rounds, and that's more prepping of cases for the following week, going over what instruments we need, making sure that we have the appropriate hardware for each case. Obviously, that's updated on a day-to-day basis, but that's something that I manage. And of course, just like any other fellowship or even residency, is the goal is to treat their patients as if they were ours. So getting to know patients, that's one of the really nice things that I do really enjoy about clinic, is being able to see patients preoperatively, work them up for those cases, see them obviously in the OR, and then see them postoperatively. It's been pretty cool. Here's just kind of an example of the various cases that we have. I hope you enjoy my really handsome dog, Loki, in his Halloween costume last year. So this is kind of just to show the various cases that we're exposed to. Like I had mentioned previously, we do a decent amount of total ankle replacements. Primarily, we use, I don't know if I can say brand names on here, but we're exposed to all different types of total ankles, and we get to go to various labs just to make sure that we're comfortable in all of those. For being a clinic and not taking ER call, we do get a decent amount of trauma, which is nice. And then you can see as far as like the lateral ankle stabilization and the arthroscopy cases, we are exposed to a decent amount of that as well. One of the requirements of the program is a minimum of 2 publishable papers, and then presenting at various conferences. AACFAS is required. The rest are, if you would like to go, if you are able to present at those things, being an AACFAS accredited fellowship program, we are very involved in AACFAS, so that is obviously a requirement. We do have something really cool at our hospital or part of our group called the Moore Foundation. And in that we have a gait analysis lab. We have a whole research team that is fantastic. And then part of this, just kind of a side note that I think is really cool, part of the Moore Foundation is every year they build and 3D print prosthetic limbs for kids and robotic limbs for them. So that's cool to kind of, I mean, not necessarily that I'm a part of it, but it's cool to have a program that gives back to the community like that. We have various previous fellows kind of all over the country. Here's just a little brief slide on that. Like pretty much all fellowships, we have benefits. We have CME. Like I had mentioned previously, AACFAS is mandatory. As far as salary goes, I feel like it's pretty good. I mean, you get to live in Phoenix. I absolutely love Phoenix. So I cannot complain. Like I was saying, 9 months out of the year, Phoenix is a fantastic place to live. The rest, you're just waiting until it's winter time again, and then you can brag to your friends that you live in 60-degree weather in December. These are some of the various locations that we go to. I don't know how familiar people are with Phoenix, but the highway system is actually really good in Phoenix. And so getting around is not bad. I know it kind of looks like they're spread out everywhere, but from where I live, it's about 25 minutes to the furthest location, which is fantastic. We do get exposure to various clinics, 2 different surgery centers, multiple hospitals, and a specialty hospital, which is all, I think, beneficial to have that exposure to. And like I said, Phoenix is just an awesome place to live. The food scene here is amazing. I'm not really here to sell you on Phoenix, but if you get a chance to visit, food scene's amazing. There's lots of great sports here, and awesome things to do. So that's kind of all I have for this. Here's my email if anybody has any questions about anything. I'm happy to answer anything. It's kind of
Awesome job. I agree. Food scene is great in Phoenix.
Okay. I made it a goal to not, my husband and I made it a goal to every time we go out to a restaurant, we can't like repeat the same one because we're like, so many places, we have to try them all.
That's awesome. That's a good one. Well, thank you guys. I really appreciate all of you being here and discussing the articles as well as tools in early job search, as well as just getting out of your fellowship or your residency and getting back to work. So thank you all for being a part of this, and I hope you all join us next month, which is June 18th, for our next AACFAS Journal Club, and we hope to see everyone there again.
Thank you all.
Have a good night, everybody.
Thank you.
Thank you so much, doctors, for joining us.
Thanks,
Thank
Mickey.
you, Mickey. Thanks, Christy.
Bye, Luke. We'll see you later.
Bye-bye. Yep. Take care. Bye-bye.
Thank you, Dr. Kubick.